Greater Manchester CLAHRC. Now, I'm not going to go into what CLAHRCs are all about, but really they have a dual purpose, research and also putting research and evidence into practice. And we're at the end of putting research and evidence into practice. And through a link with our Academic Health Science Centre, we found ourselves working with Manchester Mental Health and Social Care Trust. We really wanted to look at improving the physical health of their service users with severe mental illness, but we weren't sure how to go about doing this. So they enrolled our help because we've been doing a lot of work within cardiovascular care for people, primarily in primary care, improving the health of people with cardiovascular conditions. So it seemed like a natural fit that we would go and help them. So as the Commission rightly points out, the neglect of people's physical health cannot be allowed to continue. And these are the kind of things we need to be looking about. So access to services where physical health can be monitored, training and education for people at all levels who are dealing with people with severe mental illness, who's responsible for managing physical health and who's going to monitor that, some clarity in that, and also more regular assessments, whether that's done in primary care or in the community setting, but looking at assessing physical health more often. Now, our project within Manchester, the Trust had identified they wanted to start working with community teams, and the project and the work on physical health won't stop there, but that's where this pilot project was going to start. So we identified one community team that we were going to work with, the North West team, which has around 500 service users, approximately 30 staff. And we wanted to second some people into CLAHRC to actually work from the Trust in this project. So we had 2 care coordinators who worked with us, came on board June time of last year, and they worked 2 days a week for us for about an 8-month period. We also knew that we wanted to involve primary care in this project, so we've got 5 GP surgeries involved, and they varied in size, culture and their knowledge around mental health. I think the smallest had a list size of 4,000 patients up to 13,500 patients. And so we invited a lot of surgeries to partake, and we picked these 5 from those that came forward to us. And the project ran from June last year to March this year when we closed it. We wanted to do a very extensive sort of evaluation throughout this project, and there was a lot of work we did up front before we even scoped out the project and decided what it was actually going to look like. We call that the discovery stage, so we held a lot of interviews with Trust staff, a lot of interviews with primary care staff, and a lot of interviews with about 19 service users we spoke with as well. And then throughout the project we looked at various process and outcome measures, a lot of qualitative work again, a lot of interviews held with the same groups, and also quantitative stats where we could, and Michael will go on to explain what those were. But it's quite difficult to show a lot of outcomes in such a patient-centred outcomes in such a small or short space of time. So in terms of before the project, before this discovery stage, when we were trying to go out and talk with teams about, what was the situation like around physical health, what was the situation like around the communication and contact between community teams and primary care. And we found that from a community mental health team perspective, there was really no contact at all with GPs. GPs were not involved in CPA reviews. There was no sharing of data from the GP practice on any physical health assessments that had been handed back to community teams. And within the Trust and community teams themselves, there was very little focus on physical health. They did have 2 physical health nurses within the Trust who were used very well within pockets around the Trust. But again, some care coordinators used them, some GPs used them, but it wasn't standard care at all. From a service user perspective, there was a real lack of trust with GPs. They felt that they could trust their care coordinators, they could trust their psychiatrists, but their GPs, they weren't really very sympathetic to them. They felt there was some sort of hostility there. Definitely difficulty in accessing GP surgeries, particularly, as I said, receptionist staff. Sometimes we were having to wait for an hour in crowded waiting rooms. It wasn't acceptable to them, they couldn't do it. So we decided this was the gold standard for the Trust, and it could potentially, I think, be the gold standard for most trusts, I think, to develop and implement a sustainable, integrated service user pathway that supports prevention and the early diagnosis, treatment and management of physical health problems as part of the overall treatment and care of people with severe mental illness. And there were 2 elements that we really felt had to happen here. It needed to be a joint approach between community teams and GPs into dealing and looking at physical health. And it really needs to have shared responsibility and action and management in that physical health plan. So we knew that we needed to bring primary care into this project in a big way. So how did we achieve that gold standard? I'm going to hand over to Mike now to let us know, talk about the various project components and also the evaluation of that and the outcomes of this pilot project.
We know that Rethink are quite at the forefront regarding pushing physical health assessments. Well, in Manchester, when we started the project, there was no physical health assessments absolutely embedded in the structure. However, the Trust had agreed to use the Rethink assessments, been agreed with commissioners that was going to happen. However, the problem is that it wasn't particularly well put to CMHT staff. I don't think there's much training on how to deliver the Rethink assessment. The different skill mix of the care coordinators, some being social workers, OTs and nurses, not everyone felt comfortable. Physical health education links on quite nicely from the physical health assessments. What came out quite clearly from the focus groups was a lot of care coordinators didn't feel comfortable enough around physical health, around hands-on practical guides of how to actually deliver or know what to look for, what to assess. So what we actually did is provided some smaller bite-sized training sessions utilising the nurses Michelle mentioned before, the two physical health nurses in the Trust. Yes, they were small bite-sized sessions, they were run after team meetings or during team meetings, and they worked to an extent, but the feedback we got was that actually care coordinators would prefer a dedicated day or a couple of days focused completely on physical health. We found there was big barriers between the CMHT's understanding what existed, what those services actually delivered, and how to refer into them. And from the other side of things, the community lifestyle services, I don't think they've always worked with people with severe mental illness, and that's a big learning point. So what we did with the team is we ran 2 full-day collaborative learning sessions. We really tried to break down those barriers. The morning session was very much about the things mentioned before, so how to refer into what we provide, very much led by the community lifestyle services. And the second part was much more about breaking those barriers down. It was, what can we do to try and make the situation better? And on the back of that, what we have seen is there's been, actually later on actually, been a much better referral rate into lifestyle services. There has been some referral documents that have been slightly amended to be much more applicable for a care coordinator referring somebody into the service who's got severe mental illness. Michelle mentioned the 2 secondees that we took on board into the CLAHRC project. The 2 secondees carried out the community physical health coordinator role. It was a dual purpose role, so they acted as care coordinators for 2-3 days a week, and 2 days a week we acted as in this position. The NDT meeting is central to all of this. And as the NDT meeting, it was based in the practice. They were made up normally of GPs, the physical health coordinator, practice manager normally, practice nurse who were very influential, or healthcare assistants in the practice, and it really differed depending on each one. I think what we did well in the project was that we weren't directly saying that we have to do it this way. We used the PDSA, the Planned Study Act methodology to see what would work really. So we held the MDT meeting. At most practices they were monthly, some they were bi-monthly. Some practices we built on already established meetings. I mentioned before at the table about integrated care work. Some of those meetings we badged on the back of them, other meetings they were palliative care meetings, and in some surgeries they were dedicated meetings with just a GP, physical health coordinator and the practice nurse. Each meeting we discussed between 5 to 10 clients. How these people were selected really varied again. I mean, initially we looked at cardiovascular risk data, as I mentioned again previously, but when we went to try and do that, we found there was an awful lot of data missing. Some practices looked at people who were heavy smokers, people with big BMIs. Sometimes it was just GP suggestion of people they were concerned about. Sometimes it was people who the GP never saw and they were really scared they hadn't been to the practice. From the other angle, from CMHT, care coordinators, they also raised clients who they were concerned about physical health problems. Communication, which I thought would be a big problem between both sides, was quite simply solved by using NHS Net account email addresses. We got around the process of having integrated systems, and the GPs involved were very happy to use them. The other problem being is that trust staff don't have NHS Net accounts as their normal work is, they have a trust account. So it means setting up 2 different email systems, which can cause communication problems.